Hello, hi. My name's Dr. Bashir. I'm going to be leading the session today for Mind the Bleep, just about ABGs and VBGs. Just whoever's in the chat, can someone just say yes if they can hear what I'm saying? Hello, hi. My name's Dr. Bashir. I'm going to be leading the session today for Mind the Bleep, just about ABGs and VBGs. Just whoever's in the chat, can someone just say yes if they can hear what I'm saying? Once someone confirms, we can make a start. I'm going to be leading the session today for Mind the Bleep. Perfect. Okay, good. So, fine. We've got a couple of people who said they can hear me. Um, we'll wait until 5 past, wait until a few more people join, and then we'll make a proper start on this. The session shouldn't take too long. It's just mainly tips and tricks in terms of how to navigate ABGs, obviously how to just do an ABG and a VBG, the differences between the two, how to interpret each one, their uses, and so on and so forth. Okay, we have a few more people joining. Just to anyone who's joined new, hi. My name's Dr. Bashir. Basically, I'm a new SHO, newly just finished FY1, and I'm just leading a session essentially just for incoming FY1s. Basically, just going through over the next kind of 8 weeks or so. We'll just be going through, just mainly things that you'll be having to do on the wards, the expectations. So, for example, obviously doing ABGs and G tubes, stuff like that. So, all these clinical skills, documentation, kind of getting around the ward, and obviously, navigating some of the more complex and complicated shifts and stuff like that. So, that's what we'll be doing over the course of the next 8 weeks. So, this is the third episode of our series, I think it is. I can't remember what it was last week. I didn't do that session, but I did take the first session, which was on calls. I think maybe the last session may have been night shifts. But yeah, so we'll just be progressing throughout the weeks. So yeah, hopefully anyone who's tuned in before has found it useful. I'm conscious of time, so it's nearly 5 past, so we can make a start. And anyone who joins in the meantime or later on, the good thing is this will be uploaded onto YouTube later on, so it was free for anyone else to watch later. And obviously, if you guys kind of struggle to grasp any of the concepts, then feel free to kind of wind back and watch it again on YouTube. As I said, it'll be uploaded on our channel. Okay, this is a session all about arterial and venous blood gases. Okay, and as I said, we'll be just talking about how to take them, obviously, where to take them from, the indications, and in terms of how to really interpret an ABG versus a VBG, especially when we're looking at respiratory pathologies, and also some metabolic pathologies as well and stuff like that. And we'll run through all of these things. Sorry, just before we do start, someone asked whether the session will provide you with a certificate. It unfortunately, to my knowledge, there aren't certificates being distributed. However, specifically, if you do need one, I can give you I can drop my email in the at the end, and I can, you can just send me an email, and we can send you an attendance certificate. If it's something that's required for portfolio or something like that, I'm happy to do that. But yeah, let's make a start on this session. First we'll just talk about arterial blood gas, and then we'll move on to venous blood gases. We'll start with the important one first and the more complex one. So essentially, when do we want to do an ABG? Or when do we think about doing an ABG as opposed to a VBG? Because think about it. ABGs, I don't know whether you ever had one before. The ABGs are notoriously a lot more painful, okay, for patients. And in some cases, if patients have a very, very low pain threshold, then sometimes we actually give them some lidocaine as well in the local area before we administer or take a ABG. So, we have to be very careful in terms of when we do this, even though it's a very seemingly simple procedure, it may cause the patient a lot of harm, okay? So essentially, number one, we want to assess the oxygen status. This is the main thing. So the partial pressure of oxygen can only accurately be assessed with an ABG. So mainly with respiratory pathologies, right, we'll be thinking of an ABG. Obviously, there has to be a reason behind it. But for example, if someone's acutely hypoxic, so if they have type 1 respiratory failure, right, when we're titrating oxygen in, for example, acutely unwell COPD patients as well, we want to find what their target range of saturation is or something like that. We will do an ABG as well, and I'll explain why. When we're monitoring patients for mechanical ventilation to look at how successful the ventilation actually is in raising their partial pressure of oxygen in terms of how well they're actually saturating their hemoglobin with oxygen, how well is it actually getting through from their lungs and diffusing across their, the varying layers of the lungs to the hemoglobin, and then obviously forming a complex with it. Also, assessing their ventilation status, so not just the oxygen, but also how well they're breathing in and out. So that would be, to do with more type 2 respiratory failure. So when there's a rise in both carbon dioxide and oxygen as well. So we want to assess that. Also, patients who are in shock states or poor peripheral perfusion. The reason why is because patients in shock states will usually be very, very vasoconstricted, because obviously they're trying to get a lot of return back to their body, or try and get basically maintain a high blood pressure to go to their organs. So what can happen is the venous return might be a bit on the lower side, so therefore getting a venous blood sample might be a bit harder. So sometimes in patients with poor perfusion, so for a lot of patients who are, for example, acutely unwell who come into our resus in our A&E departments, we would do a ABG for as opposed to a VBG. And, for peri or preoperative assessments, again, to assess their work of breathing. Okay. So these are the main uses and indications for an ABG. And we'll come to a VBG, but the reason why an ABG in particular is more of a standalone thing is because with a VBG, when you're taking normal bloods from a patient, so for example, you're running troponins, usinase, and all these kind of things, you can easily take a venous blood gas while you're doing that. Whereas an ABG is a completely kind of separate procedure. You're aiming for somewhere different on the arm, and obviously you're aiming for a different part of the vasculature as well. So that's just also important to consider, that you're kind of going out of your way to do it, essentially. So in terms of the reference ranges, so what do we usually expect on a ABG? A couple of these things are not going to be any different to a VBG. So the pH ranges 7.35 to 7.45. Obviously, less than 7.35 would be acidotic, and more than 7.45 would be alkalotic. Okay, and the cause of this acidosis or alkalosis will be either respiratory or metabolic. Okay, these are the two causes. All right, and we'll go through why each thing might be deranged. Okay. And in terms of the CO2, so usually between 4.7 and 6 is what we expect the CO2 to be in kilopascals. And the oxygen should be between 11 and 13. So in a normal patient, just walking around, healthy patient, that is what their partial pressure of oxygen should be. Okay. In terms of their bicarbonate, it should be between 22 and 26. And again, this is the same for both VBG and ABG. Okay. And the base excess should be between -2 and 2. And we'll go through what all these things mean. Okay. Don't worry about it. And we just have a diagram here. Just basically essentially just showing you or illustrating, the gas exchange both at the lungs and at the tissues, right? So usually, and I'll just run through this very, very briefly, just because I think it's important just to understand some of the physiology behind it, okay? So at the tissues, obviously you've got oxygen diffusing into the hemoglobin. As the oxygen diffuses with the hemoglobin, the oxygen basically, there's the Haldane effect, okay? The Haldane effect is where oxygen will bind the hemoglobin and it will go from a T state to a more stabilized R state, essentially. And that's when it kind of conforms into an R state, it becomes or has a way more higher affinity for oxygen. So a lot more oxygen starts binding to the hemoglobin once one oxygen binds to the hemoglobin. And all of you should be familiar with the S curve and all these kind of things as well. So that's what happens there. And then usually at the tissues, you have, instead of the Haldane effect, you have the Bohr effect. And the Bohr effect is when you have carbon dioxide, which is produced at the tissues, because obviously the tissues are very metabolically active. And you have therefore CO2, you have H+, you have 2,3-BPG as well. Also that the tissues is usually a higher temperature as well, only very slightly. But so usually around at the organs, at the peripheries, because you have these things happening, the CO2, what happens is then kind of diffuses into the hemoglobin. As the CO2 diffuses into the hemoglobin, the CO2 kind of causes a conformational change, so to speak, as well. And essentially, you have this little enzyme called carbonic anhydrase, right? And what happens with this is this kind of converts when the CO2 and the water that reacts within the hemoglobin converts and it goes all the way into producing bicarbonate and H+, okay? And the bicarbonate, and this is a really important point, and we'll go on to this, is CO2 around the body is mostly carried as bicarbonate, okay? You won't really see just CO2 just kind of free flowing. And it's because of this particular equation that you just see in the corner right here. And usually what happens is this bicarbonate will then flow in the body and basically it will collect these H+ ions, okay, that are being produced essentially, and being produced by the tissues and all this metabolic activity, right, to make sure that we maintain a normal pH and it doesn't get too acidic, or obviously it doesn't get too alkalotic as well. So yeah, that's a very simple explanation, and I'll go into it in a bit more detail here. So there you go. So that's the Bohr effect there on the left of this image right here. I don't know if you guys can see my pointer. And on the right of the image at the tissues, this is the that's the Bohr effect at the tissues, and that is the Haldane effect there at the lungs. Okay, and this just kind of goes through, the respiration kind of pathway very, very quickly, or what happens with the hemoglobin and dissociation, all this kind of stuff. We've already mainly talked about this, so I'm not going to go through it in too much detail. But yeah, essentially, you have the bicarbonate that's produced, and this bicarbonate really helps restore that kind of acid-base balance. And if it wasn't for that, then we're going to metabolic acidosis, right? But we'll also talk about respiratory acidosis as well, and what can happen there. Because the main things that we're really looking at when we're looking at an ABG is we're looking at usually the kidney and we're looking at the lungs, okay? The kidney is a very, very important acid-base balance, and also the lungs are very important acid-base balance. The lung is more important because of its ventilatory support, and that is how it maintains the acid-base balance, and usually the kidney is because of its metabolic function, essentially. Basically getting rid of all these hydrogen ions that are produced by all this metabolism that's going on in the body, and essentially replacing it with bicarbonate, okay? So hopefully that makes sense. Now, in terms of just a quick run over, just try and understand the acid-base balance, okay? So we've got a little diagram here that kind of shows the bicarbonate and the CO2. So the CO2 determines whether you're in respiratory acidosis or respiratory alkalosis, okay? So this is all with the respiratory system. That's the CO2 that we're concerned about, okay? The bicarbonate determines whether you're in metabolic acidosis or metabolic alkalosis, okay? So these are the two things that we're really concentrating on. So therefore, by proxy, the pH is related to two things, and the pH is therefore determined by either the bicarbonate or the CO2. So, and this is important because when you get an ABG back, or even a VBG, right, and you see the pH, if it's deranged, you have to think two things in your head, okay? Does this patient have either an acute kidney injury or CKD, or something wrong with their kidneys, okay? Which is why they're not, able to empty. Or do they have something wrong with their respiratory system, right? Or maybe in general, they're just producing more acid than they can basically empty, right? So for example, if they're in lactic acidosis, or they've ingested a lot of, for example, aspirin, which contains salicylates, which can obviously cause some acid in the body as well. So these kind of things you have to be thinking about, really. You have to be querying any patient that comes in with any metabolic or respiratory derangement on a ABG. Okay. I will go slower, yes, because I'm concerned that I'm going a bit too quick. So essentially as well, so as I said, we've got respiratory metabolic disorders, right? Just in terms of the respiratory system, we'll go through this very, very briefly. What happens is, for example, if you're not breathing as you should be, okay, and your CO2 starts building up, what happens is in acutely high CO2 patients, so acutely hypercapnic patients, all right, you have the central and the peripheral chemoreceptors, and they will pick this up, right? And this will then stimulate your ventilatory drive, okay? So you start breathing in and out more to basically get rid of the CO2, okay? Now, in COPD patients, what happens is usually they have a buildup of CO2 and the body essentially gets used to it. So these chemoreceptors, they get desensitized, okay? So therefore, this hypercapnic drive that was kind of driving this increased, ventilation and getting rid of the CO2 isn't there anymore, right? So therefore, you're only relying on another thing, which is called your hypoxic drive, okay? And now this is where, it becomes a bit more physiological because your hypoxic drive, and this is why we aim for 88 to 92 oxygen sats in patients with COPD, you'll hear that quite a lot, is because you're relying on that oxygen drive. If you go above that kind of 92 level, right, what can happen is that hypoxic drive also diminishes. So therefore, the patient, can become obviously respiratory a bit more acutely unwell, okay, because they don't have that hypoxic drive kind of pushing them when their oxygen level comes down, or when for example, their CO2 level comes up. Okay, so this is just something to bear in mind with this particular group of people, the COPD patients. And in terms of the metabolic compensation, that's just respiratory compensation. That is mainly just ventilation. The metabolic compensation, when a patient has, for example, a high or low pH or any derangement at all on the ABG, is in three ways: getting rid of the acid just through the kidneys, bicarbonate reclamation, which is basically just reabsorbing bicarbonate in the kidneys, or producing bicarbonate through acids. So usually you have, for example, a lot of acids being excreted, such as, for example, sodium phosphate, and you also have some ammonia compounds as well. These are all in the urea that are basically being excreted and stuff like that. So these kind of compounds that are being excreted, they can actually kind of break up, and you can see in these diagrams, and they can essentially form buffers, okay? And what these buffers do is these collect H plus ions, right, in the collecting duct. And as they collect the H plus ions, therefore they can reduce the amount of acid that's there, and they can help counteract that kind of metabolic acidosis, okay? And also they can they can counteract the respiratory acidosis, because what can happen is the CO2, as I said, is mostly transferred as H2O3, but then also the other thing that's produced when you have high CO2 is obviously high H plus ions. Where are these hydrogen ions going? Usually it's the kidney that's helping getting rid of them. Okay, so that's just something to remember. And as I said, the pH is proportional to the bicarbonate in the CO2. So always think about these three things kind of all in conjunction with each other. Okay, hopefully this all makes sense. If there's any questions at all, please just put them in the chat, because I'm wary that some people may have forgotten these concepts. And this is just a quick diagram that kind of explains, which compensation is happening when. If you have something that's metabolic, right, a metabolic acidosis or metabolic alkalosis or metabolic derangement in general, right? For example, you've ingested maybe too much of a drug that produces H plus ions, right? Anything, as I said, it could be aspirin or something like that. It could be the lungs that end up basically compensating, right? When you have high salicylates in the body, because obviously it's an aminosalicylate, that is what aspirin is, okay? Whereas if you have something respiratory, so for example, if you're a COPD patient, or you might be a patient with any kind of restrictive lung disease, kyphosis or anything like that, or a chest wall disease, whatever it is, pleural disease, anything, okay? Anything that will cause your CO2 to rise because you're not able to kind of empty your lungs fully, or your ventilation is affected, then what would happen is the kidney would be the thing that would compensate, okay? So therefore, we would see, for example, a high bicarbonate, okay, on a ABG, right? Whereas with a metabolic derangement, so metabolic acidosis, alkalosis, you might see a lower CO2 or higher CO2, depending on which one, how the lung is compensating for it. Okay, so hopefully that makes sense. I think this diagram is actually really, really key. It got me through the whole of medical school actually, and still gets me through my job. So I just think it's useful to maybe just kind of rote memorize this kind of thing. Now, in terms of doing an ABG, right, before or even just after we do one, we always have to consider what the patient has come in presenting with. Okay, now obviously these are kind of three scenarios that I've given where you should be worried about the patient, even in kind of so-called normal values. Okay, if a patient has a normal partial pressure of oxygen, but they're on high flow oxygen, okay, you have to be thinking in your head, there's something abnormal going on. Okay, they're clearly not able to saturate, their hemoglobin. Basically, the oxygen is just not getting through and past the lungs and into the blood, and then therefore diffusing into the hemoglobin and getting through and binding and going to the peripheral tissues. There's something wrong in that process, basically. Okay, so you always have to question that. Also, a normal partial pressure for CO2 in a hypoxic asthmatic patient. Okay, what this usually indicates, if you have a normal PaCO2 instead of a low one, it indicates that the patient is becoming exhausted. Okay, and this kind of patient will probably need some ventilatory support. Okay, and then the last one is if you have a very, very low oxygen and a patient is usually completely well, just think about the fact that you may have taken some venous blood and sent some arterial blood. Okay, it's a very, very common mistake, but trust me, it is made in the A&E department. I've seen it made multiple times. So it's important to just consider as well. Okay. Now, in terms of how we interpret, how we look at it, okay, like I said, the pHs kind of gone through. Anything less than 7.35 is acidic. Anything, obviously normal range of 7.35 7.45. Anything above that is alkalotic. Okay, there's many different causes for that. Usually anything alkalotic, I will tell you, as someone who's worked in A&E, is not too much of a worry unless there's an obvious cause, something like hyperaldosteronism or something like that, or whatever it might be. Okay, some kind of endocrine disorder. But for the most part, it's usually the acidosis that is the main concern. Okay, so that's the first thing we look at. The first thing we look at is a pH. That's the first thing that really comes out of the ABG that we should be focusing on. The second thing is we look at the CO2. Okay, we're looking at whether it's a respiratory problem. Okay, is the CO2 wildly deranged? Okay, or is it more of a metabolic problem? Okay, and then after we look at the CO2, then we would look at the bicarbonate. Right. So as I said, these three things, we always look at it like a trifecta. Okay. And then when we look at the bicarbonate, this will kind of just determine basically whether it's metabolic or respiratory as well. So we kind of use the CO2 and the HCO3 to kind of compare and see whether do we think it's more of a metabolic problem or more of a respiratory problem. How are we going to therefore treat this patient? Okay, for example, in a patient with CKD and they're quite on the acidic side, you might see a lot of patients on the ward as you're working who are on long-term bicarbonate. Okay, and that's usually to counteract the metabolic acidosis that is caused by CKD. Okay, and obviously someone with COPD, they might be on long-term oxygen therapy or something like that, and they have other kind of things to help kind of counteract the acidosis that they would have from the CO2. Okay, that's building up. Just quickly, and one last thing that we look at as well is the base excess, and I promise you guys that we will talk about this. So the base excess, usually if it's high, so if it's more than 2, then we'll be thinking that it's mainly either a primary metabolic alkalosis, or something that's causing metabolic alkalosis directly, okay, which again can be an endocrine problem. It could be ingestion of a certain drug, okay, or something like that is causing this metabolic alkalosis. Or it could be because of a compensatory mechanism, all right? So, for example, they're compensating for the respiratory acidosis. Obviously, it's a respiratory problem, so you can't compensate with the respiratory system. So, therefore, you have to compensate metabolically, okay? And therefore, you might be on the alkalotic side, metabolically. So, you might see a high base excess than usual, okay? And usually with that, you see a high bicarbonate as well. And when it's low, obviously, you see it on the other end as well. So that's usually when it's below -2, and it would just be vice versa, essentially. It would just be the complete opposite. Okay? And just quickly, in terms of taking an ABG, there's something called the modified Allen's test. I'll be completely honest with you. I don't think anyone's ever actually done that unless someone has already a peripheral vasculature type problem. Okay, then you might do a modified Allen's test, and therefore what you do is you press on both the radial and the ulnar artery, and you would see how their perfusion is. So you press on one, and then you press on both, and then you let one go, right? And then you see if it's able to perfuse the whole hand, right? And then again, you press on both, and then you let go of the other one of the arteries, whichever one you choose, right, to do first. And then you see if it's able to perfuse. If one of the arteries is able to perfuse the whole hand, then usually that they pass that test and you could do an ABG, okay? So it's just basically to check the peripheral perfusion. And usually after you do that, what you can do is you can ask the patient to clench their fist, but it's very rarely needed because the flow through the radial artery is so good usually. you can literally puncture it, and straight away the whole syringe will just fill up. Okay, and as I said, you'd usually go in the radial artery. Okay, obviously, if you're struggling, I have seen people go in the brachial. I've seen people go femoral before, but it's very, very rare. Okay, so usually, as I said, we usually, first port of call is to take it from the radial. And now, in terms of a venous blood gas, so again, a lot of these values will be similar. So one thing that I didn't go through before, but I think it's important to mention now with a VBG, is that both VBGs and ABGs actually come up with other values apart from just the kind of respiratory and metabolic values that we're looking at. They also look at electrolytes. They also look at glucose, urea, and lactate levels as well. So lactate can obviously be important if you're suspecting something like ischemic bowel disease or anything like that. Glucose can be good as well if you're querying a seizure in someone. That could be a hypoglycemic seizure or anything like that. Obviously electrolytes as well. It gives us a very quick picture, whereas bloods, they have to go to the lab and stuff like that. This you can run immediately. And this is what I'm going to come to next. This is the main use of a VBG. As a VBG, you can kind of run these results immediately, and you can see, or maybe get a bit of a better picture in terms of what the problem might be. For example, I had a patient last week who came in. They were suffering with multiple seizures, new onset, in a patient who had no history of trauma or anything like that. And they were quite on the older side, right? And I might leave it to the floor actually to answer this. They had an electrolyte abnormality. Okay, the electrolytes are kind of all there for you to kind of see in terms of what they usually pick up a VBG and an ABG. Can anyone guess what electrolyte abnormality they had? Anyone want to hazard a guess in the chat? I'll give you guys a minute just because I thought it was a very interesting case actually. But it was very, very grossly abnormal, the VBG. Anyone want to guess at all? I think everyone's just being a bit shy. Maybe give you like another 10, 15 seconds. Okay, we've got one answer. Anyone else want to answer? Okay. Fine. So yeah, you're right. So they were grossly hyponatremic, and this is what you'll see. The patient's level was, I think it was like 105. It was something grossly abnormal. And anyway, so yeah, so that's what it's really useful for. Okay, you can find these kind of results immediately, whereas with bloods that go to the labs, they might take an hour or even 2 hours. Okay, in terms of everything else, really for respiratory pathologies and stuff like that, I don't really use it, but sometimes. And I have seen doctors do this, where you can actually use the partial pressure of CO2 as a bit of a guide in terms of what the problem might be. Okay, because usually the venous PCO2 is about 3 to 8 degrees higher than the arterial partial pressure of CO2. Okay, so this is just something to note. But if it's, for example, on the very, very high side, the CO2 on the venous blood gas, then, for example, you could be like, okay, there might be some kind of pathology there that's obviously like a respiratory pathology, right? And therefore, you might do an arterial blood gas. However, if it's usually, for example, on the very, very normal side / on the bit of the lower side, you might just say to yourself, you know what, it's not worth hurting this patient. I might not do an ABG in this case. Obviously, it depends from patient to patient. Sometimes you have to do an ABG. But I'm just saying, if it's a patient that might not really require it, the VBG might push you to the edge to be like, you know what, I've looked at the CO2, it doesn't really look grossly abnormal and actually looks a bit on the lower side. And obviously, bearing in mind that it's usually higher than the arterial anyway, but it's not grossly higher, then you can assume that the arterial might be in the normal range. Okay, this is just something to consider. So as I said, the PCO2 and the PO2 are the only things that are really different out of between the VBG and an ABG. The rest are entirely the same. Okay. And in terms of the uses of a VBG, I feel like I've kind of just gone through this. But the main thing is really, and this is what we use it for in A&E, is we just want to measure key metabolic values. That's the main thing, okay? in any acutely unwell patient, we want to look at their electrolytes, we want to look at their lactate, and we'll look at their glucose as well, and even their urea too, because that can obviously indicate a GI bleed as well. So these are kind of like little kind of good things that might point you towards a certain direction in terms of how to approach the patient. And obviously you put it with their clinical signs and symptoms as well. And once you put everything together and obviously their blood results come and all this kind of stuff, then you can make a decision in terms of further management for the patient and further investigations as well. Also, one other thing, and this is important to note, is in patients with DKA, or in patients with sepsis, or in patients with severe hypoglycemia that have come in, with symptomatic, then it might be useful to do serial measurements of the VBG as well, because then you can see or monitor their improvement, okay? And even with electrolytes, so for example, if you want to look at sodium and stuff like that in hyponatremic patients, we did serial VBGs literally every hour, or every time they were given an infusion of very hypertonic saline. Then we would do a VBG. So these are just some of the uses, okay? Another thing as well, and this is kind of what I touched on, is it can help to kind of indicate in terms of patient's respiratory function, okay? Without any need for an ABG, and therefore without any need to kind of put the patient through something quite painful, okay? Just by looking at the PCO2, essentially, all right? But as I said, and this kind of the overarching theme, if a patient is acutely unwell with some kind of respiratory pathology, then usually we would just go for an ABG, okay? But the point is that the first kind of port of call is when a patient comes into A&E, as we do their bloods, we always do a VBG anyway. So it's always good to just look at as well, just to give you a bit of an indication, okay? So hopefully that makes sense. And that's it. It's a very, very short session, I know. It's only half an hour long, but these are really the main core things that you guys need to know. I hope that I've gone over everything. Any questions, I'm more than happy to answer, and I'm happy to drop my email in as well. I think I just got an email from someone who works for Mind the Bleep, one of the people who leads our sessions as well, and they told me that there will be certificates as well for people who attend. So that's just something for you guys to know. But yeah, if there's any questions, please let me know, and please fill in the feedback forms. It really, really helps when we, go ahead and venture on and create new sessions for you guys. So yeah, hopefully you guys enjoyed it. I'll leave this screen up for a few minutes, and I'll be kind of live for a few more minutes just to answer any questions that you might have. Okay. Okay, it's been a few minutes. Anyone who hasn't filled in the feedback form, again, I don't want to sound like a broken record, but if you can fill it in, it's really, really helpful. I hope you guys enjoyed the session, and join us next Thursday as well. We'll be doing this. It'll be on a completely different topic, but it'll be to do with helping you kind of get through FY1, especially settling in, and kind of just, quote unquote surviving it. Okay. So yeah, thank you for joining. Have a good rest of your evening, and hopefully see you guys next week.